Rather than continuing to teach older practices, is it time to modify load pre-treatment for rapid sequence intubation? How can you make it more applicable to the patient in front of you? What patient-specific considerations do you have before recommending paralytics and induction agents? Hello there, farmers and friends. Mark with Pharmwyze. I'm a board-certified emergency medicine pharmacist that makes clinical pharmacotherapy content. Thanks for joining me on the Code Blue Debrief YouTube and podcast series. We'll discuss evidence-based medicine and pharmacotherapy topics for emergency medicine and critical care learners. The focus of our discussion today is going to be on rapid sequence intubation, specifically pre-treatment as we process through the 6 Ps of RSI. The other day, I was making some rice and I had to stick my finger into the pot because I didn't have any measuring cups. My mom taught me to measure up to the knuckle and have the finger end touching the rice for a perfect pot. It's just something I continued to do as I left home for college and pharmacy school. Living on your own apparently affects the quality of rice you buy, at least per my mom's standards. Winco and Walmart rice tasted just fine to me, but strangely, the finger knuckle technique was never consistent. Why was I even sticking my finger in rice when there's measuring cups? You just get that feel for how much water to add, and measuring cups really never fail, especially when you're experimenting with different brands. That's what I've come to realize with critically ill patients and rapid sequence intubation. We've been taught something that has limited utility for the patients in front of us. Over time, I've adapted my approach for such high acuity patients based on the usefulness, patient-centered care, and needs of the patient. Rapid sequence intubation, or RSI, is the preferred technique to secure an airway in the emergency department. This is done to optimize intubating conditions and prevent physiologic reflexes such as the gag reflex as an endotracheal tube's being passed. The brain normally maintains its own perfusion via autoregulation. In the setting of a severe traumatic brain injury, patients can have loss of autoregulation function, leading to abrupt changes in intracranial pressures. That was the initial intent of going through pre-treatment in the 6 Ps of RSI to mitigate those elevations of sympathetic response. What you got in your hand there? A neuromuscular blocking paralytic? Who's watching your patient? Prior to securing an airway, going through the 6 Ps of RSI allows for a systematic process for ensuring personnel and equipment are available, oxygen reserves are optimized, in addition to selection of pharmacotherapies. The 6 Ps of RSI include preparation, pre-oxygenation, pre-treatment, paralysis and induction, placement of tube, and post-intubation management. Within preparation, the team should be gathering necessary personnel, equipment, and medications to bedside. Pre-oxygenation allows the lungs to saturate with oxygen to reduce the incidence of desaturations during periods of apnea. Pre-treatment considered the use of lidocaine, opioids, atropine, and defasciculation dosing. Paralysis and induction provides amnesia and relaxes the vocal cords. Placement of tube provides confirmatory diagnostics of correct positioning. And lastly, post-intubation management consists of sedation, analgesia, ICP, and vasoactive management. Pre-treatment was originally used with the acronym LOAD, which stands for lidocaine, opioids, atropine, and defasciculation dosing. These treatments were initially intended to blunt the sympathetic response and mitigate elevations in intracranial pressures in severe traumatic brain injuries. What does the eye test say? Any anatomical or traumatic obstructions? Do you identify any airway challenges that would prevent a clear view of the vocal cords? Be proactive rather than reactive when you're dealing with hemodynamically unstable patients. These should have been considerations during your initial assessment. That's a lot of patient-specific information to keep in mind during rapid sequence intubation that should be addressed during pre-treatment and prior to paralyzing a patient. Let's briefly discuss the outdated pretreatment load, and then get into how I have modified the acronym to make it more pertinent and applicable to my practice. Lidocaine is a class 2B sodium channel blocker that's primarily an antiarrhythmic. It does have analgesic properties, but it's more systemic anesthetic effects that reduce the sensitivity of reflexes, including the gag reflex. Doses greater than 1 mg per kilogram have shown to suppress the incidence of coughing. However, evidence challenging the clinical benefit in relation to neuroprotective properties has led experts to no longer recommending this practice or supporting its routine use. The Emergency Medicine Journal released the meta-analysis in 2001 that associated lidocaine prior to RSI having no benefit in reducing ICPs or neurologic outcomes. It's important to note that trials have not associated use of lidocaine with negative outcomes. Opioids have the most evidence for neuroprotective properties from extensive literature and anesthesiology. Fentanyl is a rapid-acting synthetic opioid commonly used to prevent the sympathetic stimulation from an endotracheal tube being passed. The dosage range can be from 1 to 3 micrograms per kilogram, with an expected duration of 30 to 60 minutes. Pretreatment fentanyl has been associated with prevention of increases in blood pressure, in addition to release of endorphins and norepinephrine. That's nice that fentanyl is useful. How does it fit in your clinical practice? Considering the patient population, these patients are often high-risk patients with hemodynamic instability. Not every patient is going to be appropriate to push RSI drugs right after an IV push of fentanyl. Tiang and colleagues completed a double-blind trial in 2020 assessing the stress response attenuated by fentanyl during endotracheal intubation in 145 patients. All patients received midazolam 0.05 milligrams per kilogram, lidocaine 0.5 milligrams per kilogram, propofol 2 milligrams per kilogram, and rocuronium 1 milligram per kilogram prior to induction. Patients would also receive 2 micrograms per kilogram of fentanyl 1 minute, 2 minute, and 3 minutes prior to induction. For their outcome, hemodynamics were recorded 10 minutes after induction. From their analysis, fentanyl 2 minutes prior to induction provided the least fluctuations in hemodynamics. I don't bring this up so you can use this massive pre-treatment cocktail, but to consider the timing of fentanyl to maximize the intended benefits. Slamming fentanyl into an IV line without consideration of additive effects, or how that just went over 5 seconds, might do more harm than good. Caution with fentanyl-induced hypotension, as this can contribute to neurologic injuries. Utilize the lower end of the dosing range, as this should be sufficient, and adjust per hemodynamics. Bradycardia is an uncommon yet serious adverse effect of succinylcholine. It occurs more often in pediatrics, although instances of bradycardia can still occur with pretreatment atropine. The 2015 Pediatric Advanced Life Support Guidelines recommend limiting the use of pretreatment atropine. The initial thought behind using defasciculation dosing was utilizing a non-depolarizing paralytic prior to succinylcholine to prevent fasciculations. It was believed that fasciculations contributed to increased ICPs and hyperkalemia, where giving a paralytic would reduce that risk. It appears that this was more of an inferred practice from patients undergoing elective surgery with brain tumors. My modification of load is more intended to be more proactive and allows you to anticipate airway complications. You can give medications prior to paralyzing the patient, but going through pretreatment is more about the thought process of anticipating complications and taking a step back just in case things go south. A difficult airway with subsequent hypoxia can lead to numerous negative outcomes, including anoxic brain injuries, cardiopulmonary arrest, unexpected surgical airways, arrhythmias, and death. As I go through load, I think of lidocaine, opioids, access, and down or delay. Ask yourself the following questions for each component. Is this an indication for topical or nebulized lidocaine for an awake intubation? Does the patient need opioids for pain control or neuroprotection? What access do I have to get the medications into the patient? Does the patient need agents for vasoactive support or delayed sequence intubation? An awake intubation should be considered anytime there's concerns for a difficult airway. Nebulized lidocaine 4% has been shown to provide adequate airway anesthesia. This may also be a consult reminder to get a specialist experienced with these awake intubations. We'll skip opioids because we already talked about the neuroprotective properties. Let's get into access. Knowing what medications to give does the patient no good if you can't get the drug into the patient. As the pharmacist, you need to know alternatives based on available access on the dime. Is the patient altered and combative? Give ketamine intramuscular to obtain access. This could also serve as induction if IV access is obtained quickly. Does the patient need contrast for imaging? You'll need a separate line for post-intubation sedation continuous infusions. What intermittent strategies do you have to maintain sedation without delaying scans? You never know when you might be the one asking for an intraosseous kit. Delayed sequence intubation is the technique of delaying administration of paralytics when there's uncertainty of passing an endotracheal tube. Some patient conditions may include inflammation from angioedema or a stout neck from a morbidly obese patient. The physician will continue towards awake intubation or delaying paralytics with a caveat. Agents for delayed sequence intubation are physician dependent. The intent is to maintain respiratory drive as the clinician attempts to take a view of the vocal cords. Ketamine would be an excellent choice as it prevents respirations and dissociates the patient. With a clear view, a paralytic can be pushed. It would be preferable to have an agent that is rapid acting and quick offset. Procedural sedation dose of propofol is another alternative but has limitations. The original use of load has fallen out of practice for severe TBIs, but yet the acronym is still discussed and taught as a part of pretreatment. Out of lidocaine, opioids, atropine, and defasciculation dosing, opioids are the only intervention with neuroprotective properties. I've modified the acronym LOAD to lidocaine, opioids, access, and down or delay. Consider these questions for each. Is this an indication for topical or nebulized lidocaine for an awake intubation? Does the patient need opioids for pain control or neuroprotection? What access do I have to get the medications into the patient? Does the patient need agents for vasoactive support or delayed sequence intubation? Going through each component allows me to anticipate airway complications. Consider applying it to your practice if you found value in modifying load in this manner. I appreciate you being a part of the first Code Blue Debrief YouTube and podcast episode. Make sure to hit the subscribe and notification bell. And as always, I hope you learned something new.